She was 47 years old. She had not slept through the night in 8 months. She was waking up at 3 a.m. drenched in sweat. Her mood was unpredictable. She had gained weight around the middle without changing anything she ate. She was forgetting words in the middle of sentences, and she'd been to a doctor twice. And both times, she was told the same thing. It's probably stress. Try and get some sleep. Try and get some rest. Nobody mentioned perimenopause. Nobody mentioned hormones. Nobody mentioned that what she was experiencing had a name, a clinical explanation, and in many cases, an effective treatment. So she came to the pharmacy asking if there was something she could take for hot flashes. And I remember thinking, this woman does not need a supplement. She needs a conversation with her doctor, and she never had that with her doctor. And that conversation is what this episode is. So, welcome to When Food Meets Medicine. Before we begin, a quick note. Everything on this show is for educational purposes only. It does not replace your doctor, your pharmacist, or your healthcare team. So, always please consult your care team before making any changes to your medications, your diet, or your treatment plan. And if this conversation helps you, please subscribe. It is free. It takes 10 seconds and it means you never miss an episode. Welcome to When Food Meets Medicine, the podcast where we explore how what you eat affects how your medications work and how the choices we make every single day shapes the health we carry for a lifetime. So, I'm Dr. Remy Lukoya, a pharmacist, founder of Pharma Plant Systems, and someone who believes that every woman deserves a healthcare system that actually listens to her. So this is season 2, episode 2. And today we're having the conversation that millions of women have been waiting for about hormones, perimenopause, menopause, mental health, and the medications and foods that interact with all of it in ways most women are never told. My guest today is Dr. Tope Roberts, a family medicine physician based in Calgary, Canada. And she works with women navigating exactly these transitions every single day. She brings warmth, clinical depth, and the kind of honesty that makes patients feel seen rather than dismissed. Dr. Roberts, welcome to When Food Meets Medicine.
Thank you so much, Dr. Lukoya. It's a pleasure to be on your show. And yes, this is a topical issue. Everybody's talking about it. Let's look into the medicine and let's look into the science as we start our conversation today. It's a pleasure to be here. Thank you for having me.
Thank you. I like that, the science of it. You know, as a pharmacist, I see women come to my counter all the time. They pick up thyroid medications, antidepressants, blood pressure medication, and so often the hormonal picture underneath all of this prescription is never discussed. And that gap is exactly why I wanted you on this show today. Dr. Roberts, I want to start at the very beginning because I think a lot of women do not realize that what they're experiencing has a hormonal explanation. So when a woman comes into your office in her early to mid 40s with fatigue, in for weight changes, mood swings, poor sleep, what is the clinical picture you're seeing? What is actually happening in her body?
So, as women, the big first celebration is when we start our periods, isn't it? And as young girls, that's one thing our parents would tell us about, our friends would tell us about, and luckily these days, even our teachers would tell us about. So that's a natural process, and it marks the beginning of the reproductive years of a woman. What makes this period really nice is a hormone called estrogen, which works along with so many other hormones. One for full female development, for the release of eggs, for those of us that want to have babies. And then as we start to hit that age 40 to our mid 40s, we start to experience some changes because the eggs in our ovaries that produces that hormone called estrogen starts to decline. And so as the numbers start to decline, so does the amount of the hormones that's produced is that starts to decline too. And so what we find, and usually the hallmark of what we now refer to as the perimenopause or menopause transition or the beginning of menopause, and I'll get to that, is that the limitation or the lower amount of estrogen starts to manifest. The first and hallmark symptom is a change in our periods. So if you've been a woman that has had regular periods, your periods have been like clockwork, except of course when you're pregnant, when you don't get periods, or maybe when you're on birth control, when you don't get periods. So if everything is natural, you've never had a hysterectomy, you're not on medication, you've not
Yeah.
had chemotherapy, because so many things can affect your period. So I'm talking about the woman that doesn't have any other external medication or disease condition, we start to see the periods change. So usually that's the first thing we notice. And then comes the impact of the lower estrogen. And this would manifest as some of the symptoms you've described: the brain fog, the fatigue, the night sweats, and the hot flashes. These are what we tend to experience when women, or most women will experience when they present to me. So they come with those changes and they say to me, "Oh, I feel this way. I don't have libido. My joints hurt. I feel tired all the time. I can't think straight. What's going on with me?"
Wow. And quite interesting. Thanks for that explanation. I
Sure.
know from the pharmacy side, what I notice is that these women are often already on medication for either sleep, for
Mm,
mood, for blood pressure before anyone has even checked their hormones.
yeah,
So the treatment is treating the symptoms, but the underlying picture is hormonal. And that
exactly.
distinctions matter enormously for how we manage everything else. So
Absolutely.
can you share maybe a patient story, someone you've actually worked with, where
Sure.
connecting the dots on our hormonal picture changed everything? The moment where she finally had a name for what she had been experiencing.
So I had a woman, and I think she gave herself this name, Scatterbrain. She just felt suddenly, being a teacher with little kids and everything, as her kids grew older, and of course she grew older, she just found that her mood was all over the place.
Mm.
She always had this brain fog. She'll forget things. She'll drive out of the house sometimes and she'll have to remind herself where she's going. So for her, it presented more like a mental health thing. And when
Mhm.
she initially came to me, the focus was on that mental health, because I felt, okay, maybe you have a bit of anxiety, maybe you're not sleeping well. But with time, when she started saying, "You know what, Dr. Roberts, even my periods have been all over the place." And that for me was what clinched it, that, oh, could this be perimenopause? And we had discussions about her treatment options, and eventually we gave her the required treatment. Now, I'm very careful with talking about treatments, because it's not everybody with perimenopausal or even menopausal symptoms that need menopause hormone therapy, which is what we used to call HRT, or hormone replacement therapy. So not every woman will need hormones, as it were. There are so many other strategies that can be used. So this woman got the appropriate treatment for her.
It's good. Lucky her, because a lot of people live with it for so many years without
Mhm,
knowing. So,
mhm.
at what age does perimenopause typically begin, and why do so many women they get completely caught off guard when it does? They're not expecting it.
So the age for perimenopause would vary, but for most women, it will start in about the mid 40s. Some women will start earlier in their early 40s. And unfortunately, some women will start in their late 30s. Some
Mm.
women with a
Oh,
family
wow.
history of early menopause may actually start to experience perimenopausal symptoms as early as their late 30s. But on average, it's usually in the mid 40s. And then we just have the ongoing decline, as it were. I hate to use that word, but when I say decline, I mean decline in the hormone levels that we talked about initially, and
Okay.
then symptomatology, which could be mild, that some people will go, "Oh, you feel that way? You have hot flushes?" But no, I sleep good. So symptoms
Mhm.
could be mild, it could be moderate, and unfortunately, it could be quite severe for some women, where they can barely function and where they do need pharmacotherapy.
You'd mentioned HRT, which is hormone replacement therapy. So I want to talk about that
Sure,
because I think this is the most misunderstood treatment in women's health.
sure.
And a lot of that misunderstanding, I think it traces back to there's a study from 2002. So I think my question, can you explain what happened with Women's Health Initiative study
Sure.
and why the fear it created about HRT has lasted so long, even though the science has been significantly reinterpreted since then?
Absolutely. So this was a big study that was conducted, as you said, several years ago. and they chose women that were older when they did this
Mm.
study. So being
Mm.
older as a woman, even as a human being, puts you at
Yeah.
risk of several other diseases, such as cancer, diabetes, coronary artery disease, high cholesterol. And of course, these women were also experiencing menopause because of
Mm.
their age, or transitioning into menopause because
Yeah.
of their age. So what happened? I actually think an arm of the study had to be stopped early because they found that women were having heart attacks, some were developing clots, some were developing strokes, some had cancers. And
Mm.
unfortunately, that was attributed to the hormone replacement at the
Mm.
time, not taking into cognizance all the other comorbidities that these women had that
Right.
put them at a higher risk of those diseases.
Mm. Mm.
Currently, most of those findings have been debunked, and menopause hormone replacement therapy is safe for the right patient. That's because there are still contraindications, absolute contraindications to the use of hormone replacement in women. But I'll say for the majority of women, hormone replacement therapy or menopause hormone replacement is safe, can be tolerated, and we can even use it in the perimenopause. So we don't need to wait till the menopause, which we are yet to define. And a woman that is in menopause would not have had a period for 12 consecutive months. Again, in the absence of any underlying medical problems, medication, surgery, or chemotherapy that might affect their natural transition into the
Yeah.
menopause. So we're looking at 12 consecutive months. So most of the findings from that study has been debunked. Hormone replacement is safe for the majority of women. And in fact, we're advocating that women start it sooner rather than later. As much
Mm.
as possible, we want women to start this as soon as they need it, which for most
Mm.
women could actually be as early as the perimenopausal period in their mid,
Mm.
late 40s or even in their 50s. By the time a woman gets older and is starting to hit the age of 65, the risk increases. Therefore, where
Mm.
most physicians are less likely to just start the woman
Mm.
on hormone replacement at that time.
So let's say you have a patient, they come
Mhm,
to you
mhm.
and they're afraid of HRT, they're
Sure.
afraid of the breast cancer risk, afraid of the side effects. How do you open that conversation? What do you actually say to her?
So again, we go by the evidence. Definitely, it's okay to acknowledge their fears and concerns about the Women's Health Initiative study, but to also let them know that there has been further research that has shown that the treatment is safe. Still, it has to be individualized. And I mentioned this at the beginning, that not every woman with a menopausal symptom is going to need menopause hormone replacement therapy. So if your symptom, for example, is more mood, like in the patient I talked about earlier, then we
Yeah.
may want to look at SSRIs or SNRIs, which are equally effective in treating your mood disturbances as a result of the perimenopause or the menopause. If, however, the majority of your symptoms is because of estrogen deficiency, so you're getting things like hot flashes that's keeping you up at night sweats, in addition to some of the other symptoms like irritability and all whatnot, then you could be a candidate for hormone replacement. Again, it still has to be individualized. I need to look at that patient as a patient. What are your
Mhm.
comorbidities? What's the family history? Is she a smoker? Does she have a history of estrogen receptor positive breast cancer? Does she have an individual history of recurrent thrombosis or blood clots, either in her lungs or in her legs? Those are the things. Does she have liver disease that's
Mhm.
active? Because all those will be absolute contraindications to the use of hormone replacement therapy. So it may not be for everybody, but for those where we've
Mm.
individualized and done a risk assessment, it
Yeah.
is very, very safe. And I want to put this in. Hormone replacement, as you well know, comes in different formulations.
Yeah.
So you can take it as a pill, you can use it as a patch, you can use it as a gel. And for
Mm.
people that maybe have a bit of a, I'll use the word wonky liver function, where
Yeah.
it's not really an absolute contraindication, we may choose to use a topical as opposed to an oral medication, because the one you put on your skin as a topical agent is either as a patch or as a gel, bypasses the liver, what we call the first pass effect. So you still get the benefits without beating up your liver, as it were. So we individualize treatment, but as I mentioned, for the majority of women, menopause hormone therapy is very safe.
I want to add the pharmacy perspective here because what I see is women who are on 3 or 4 medications and managing symptoms of menopause, sleep medication and antidepressants, some with blood pressure drugs or even cholesterol. When one well managed hormone conversation might have changed the entire picture, the polypharmacy of untreated menopause is a real an underappreciated problem. What role does nutrition play in managing menopausal symptoms? Things like soy, flaxseed,
Sure.
calcium, do they actually work or is that mostly wishful thinking?
Well, what I'll say is that it's not wishful thinking. I would say they're contributory or they're adjuncts to good treatment of menopause symptoms and even the experience of the menopause transition. What happens when the estrogen drops? It's more than just the hot flashes. It's
Yeah.
what happens to your bones. They get more brittle. They're more likely to break. So we talk about bone health. Your bone health, you can start with your diet. So things like dairy, calcium, very important. Again, when we're talking about the women's health study, we talked about older people or older women and men having more comorbidities. So you're more likely to have hyperlipidemia, for example. So if you look at your diet and you say, you know what, I want to up my fiber. I want to choose and opt for healthier fats. For example, plant-based as opposed to animal-based. All of those would help you with giving you more cardiovascular protection that would, on the long run, help you even as you transition through menopause. So your bone health is important. Heart health is important. Diabetes is another big one, which we all tend to get as we grow older. And then don't forget, with the perimenopause, menopause, our metabolism also slows down. So hitherto, when you were in your 20s and 30s, as Africans, you could eat a big bowl of your pounded yam and your egusi and whatever, but that's very dense in calories. And you probably have been able to burn it off easily. But in your 40s and in your 50s, it really doesn't work that way. So you need to look at your plate again and say, what proportion of my plate is actually carbohydrates? It can no longer be half of your plate. We've got to switch that to half vegetables, a quarter healthy proteins, and then you can have good carbohydrates. So that's where your seeds come in, the oats, the flax, quinoa, and stuff like that. So we need to rejig and rethink the way we put our food together as we navigate the perimenopause and the menopause, because a lot more is happening in our bodies.
Well, good that you brought in the food aspect of it because I want to bring in the food drug angle. Are there foods or supplements that interact with HRT medications in ways women should know about? Things that maybe affect how the hormones are absorbed or metabolized?
Right. So basically, for foods, one thing that comes to my mind with supplements. Did you say food or supplements? Can you take that again? I
Both.
didn't take
I
that.
said both.
Okay,
You
so
want me to? Yeah.
let's talk about supplements. One that most women tend to rush to is the St. John's wort. And this is advertised as the perfect drug to help your mood and all whatnot. But what we
Yeah.
need to know scientifically is that it is an enzyme inducer. And what this means is that if you're taking a drug like an oral estrogen that's metabolized or part of the pathways through the liver, and this supplement is enhancing the way it's metabolized. So if we give you the medication, it might not be as effective because it's getting out of your system so quickly. Therefore, that's where you come in, Dr. Lukoya, that where people need to say, hey, these are the multivitamins I'm taking that you need to now cross-check with the prescription. On the flip side, though, there's certain vitamins and supplements that I always recommend, and that's evidence-based for patients. One of this is calcium. While we can get calcium from our food, the question is, are we getting enough? And I love the fact that you have an app where people can actually see how much calcium is in this glass of milk that I'm taking. Because
Yeah.
what we recommend for women in the perimenopause and menopause is 1,200 milligrams of calcium every day. So even if you're
Mm.
taking your glass of milk, if you're not getting that 1,200, which I doubt you will with just the glass of milk, you need to be taking
Mm.
a supplement to
Yeah.
supplement or to complement what you're taking in your diet. And there are a lot of
Yeah.
calcium calculators that are available that you can use
Yeah.
to calculate how much calcium is in my cheese, my milk, or whatever else that you choose to eat. The other supplement that we tend to push, especially for bone health, this is evidence-based, is your vitamin D. And
Yeah.
what's recommended is 2,000 international units every single day. Those are very, very essential. There might be a few drug interactions with these, but I'm sure they're really minimal. That's not my
Yeah.
forte. Usually the pharmacist will check that out for us, but definitely
Uh,
some multivitamin. The other one is magnesium, actually. And I actually use that these days. And what I recommend is the magnesium bicyclinate for
yeah.
women that really struggle with sleep problems, people that wake up in between. It's something that they may want to
Yeah.
try to see. Of course, check with your doctor and pharmacist to see if that does help. It helps with sleep. It's good for your bowels. For patients with restless legs, there might also be some benefits. So there are good supplements out there, but I believe this is a conversation you should be having with your physician and your pharmacist as well.
Yeah, and I totally agree. The calcium and vitamin D that you mentioned is also quite important because they actually help with each other's absorption into the bone. So you're getting
Exactly.
an added advantage with that. So I do want to talk now about mental health because this is an area where I think women are particularly underserved. Depression and anxiety affect women at roughly twice the rate of men. And yet the hormonal connection is rarely part of that conversation. So, Dr. Roberts, when a woman comes in presenting with let's say exhaustion or brain fog, like we mentioned, sleep problems, low mood, the emotional picture is not immediately obvious. How do you approach that? How do you create a space for that mental health conversation in a 15 minutes appointment?
Can be a little tough, but of course, if you're in family medicine, I believe you need to know your patients, right?
Mm,
So the conversation will start with who you've always known Mrs. Jane or Miss Jane to be,
mm,
right? So Miss Jane has always been really chirpy, happy-go-lucky person, always vibrant, always positive. And then you
yeah,
start to notice a change, even in her behavior. You start to
yeah,
notice a change in, the way she's worrying about a lot of things, which she might mention. Usually they don't want to because nobody wants to be labeled as
yeah,
having mental health problem. But
yeah,
this is something we need to normalize and that I normalize. We all go through stresses. And so
yeah,
it's always good to be observant, one, because rarely would a patient bring it up with you that I'm feeling down. It's usually when maybe they're at the end of their tether or just say, hey, it's because I'm in menopause. It's because I'm in menopause.
yeah,
But it's a conversation that we need to have. So being proactive as clinicians is very important. The second thing is to know that this is very common. What I tell my patients is if you go to a concert or you go to a party and there are 100 people there, 10 of
mm,
them probably have mental health problems. So
mm,
you're not an odd one out. And the mental health problems can be managed. So we manage diabetes, we manage high blood pressure, even though we don't necessarily see mental health problems. Of course, we can see if the patient has become psychotic and all, which is really the terrible end of the spectrum. We may not be able to see it, but that doesn't mean that it doesn't exist. So it's
mm,
destigmatizing that condition and making it okay to tell your doctor that, hey, I'm struggling here. Another opportunity that I, as a clinician, would use to bring up mental health
mm,
concerns is during physicals. Because, yes, I know 15 minutes is a short time. I can be
yeah,
proactive, but even educating my patients that it's okay not to be okay. And you can talk about it. That's very important. So, as part
mm,
of all the questions, and like when you do a review of systems on your patient, is also to
mm,
review their mental health to see how things are going. There are three easy questions that you can ask them. How have you felt in the
mm,
last 6 weeks, two
mm,
months? How have you felt? Have you had negative thoughts? Have you felt very anxious? Have you had thoughts that you'd be better off not being around here?
mm,
Asking those really simple questions can really be helpful. And letting patients know that they don't have to put up and cope with a severely low mood or terrible anxiety just
Yeah.
because they're in menopause. There is treatment for it, and we should destigmatize and talk about it. And I know women are excellent multitaskers, and we can get on top of 1,000 things at a time, but it's also okay not to be okay and to seek the help that you desperately need. And
Yeah.
doctors, we're all here to help you and support you through the journey.
So important. So important that we
Mhm.
speak up and we seek for help. Dr. Roberts, what is the relationship between perimenopause and depression? Is it hormonal? Is it situational? Or is it both? And does that distinction change how you treat it?
All right. So there is definitely a relationship between perimenopause and mental health. Was that your question? All right.
Yes.
Let's paint a scenario. I'll go back to Miss Jane. So Miss Jane has been happy-go-lucky, really lovely lady, and then suddenly she hits her mid-40s. Her periods are worn all over the place. She's having hot flashes. She's not sleeping at night, night after night after night. She cannot think straight because of her brain fog. Her joints hurt. Everything is she sees her partner and she's like, don't even come near me. Her
Mm.
libido is out. She has kids that are leaving home, going to college. So if you can imagine having to cope with all those changes,
Yeah.
that in itself is enough to set an individual off into depression or anxiety because you're not sleeping, you're not functioning. You go to work, you're making mistakes. So that usually is what tends to happen, at least in my experience, in a lot of women that I see in my practice. They don't come to me saying they have mental health, but you see that they're not coping because at work they're not functioning. Their husband is maybe threatening a separation or a divorce. They're having to deal with empty nesting because their kids
Yeah.
have left home. And then on
Yeah.
top of that, they're not sleeping at night. That's enough to take anybody off. And so
Yeah.
you find that this now tends to accumulate week after week after week. And then you don't even want to get out of bed when you wake up in the morning because you're so
Mhm.
low. You don't want to hang out with your friends because you're no longer interested. Your
Mhm.
concentration at work is not the same. What I'm saying there is the question I would use to assess you for depression. And unfortunately, some women can get depressed. On the other hand, get really, really anxious with what's going on.
I know from a medication standpoint, this is something I would want our listeners to hear clearly. So, antidepressants work differently in women depending on where you are in your hormonal cycle. Estrogen affects serotonin. When estrogen drops, as it does in perimenopause, the antidepressant that was working may suddenly feel less effective. And that
Mhm,
is not a mental health failure, that is a hormonal shift affecting drug metabolism.
mhm.
So, Dr. Robert, are there nutritional strategies that support mental wellness alongside medication for women who want to do everything they can and just not rely on a prescription?
Supplement wise, I know there's several things. The question with supplements is the evidence. How
Mm,
strong is the evidence for
mm,
you? And that's as a scientist, that's what I always say. So hardly will you find me, apart from the supplements I've talked about, recommending one particular supplement over the other. I always sit and say, what is the evidence? And when I say what is the evidence, I just don't want to see a write up or a case report. I want to look at the strength of the evidence. So if there's supplements out there that have a very strong and a good quality study, and I'm talking randomized control trials and
yeah,
studies at that level, I definitely will review such articles and I'll be
yeah,
more than happy to recommend it to patients. And I'm sure there's several medications people can use. If, for example, you're not eating too well, your iron may be normal but suboptimal. Same with your B12, may be normal but suboptimal. There is no harm in taking maybe a multivitamin supplement so you're getting your iron optimal. At least for my environment, the normal is 20 to 300. And I always say to my patients, if you are 25, you're normal, but you're not optimal because based on research, you need at least 35 international units of ferritin to sleep well. And that takes me
mm,
to other problems. Sorry if I digress. hair
No, please
loss.
go ahead.
Lots of hair changes occur in our hair during the perimenopause and menopause. Women will come to me and say, my hair used to be so full and now I've lost it. I'm losing hair. What's going on with me? And oftentimes it's the hormone changes, is the lower estrogen. And then you can imagine having a low iron on top of that. So you need to make sure you're optimizing all of these and even some micronutrients like zinc, selenium, and all whatnot that you need to be taking to really optimize the full picture. But whether that's going to be enough to treat, I would rather wait and see the evidence and the quality of the research that's thrown at me.
Makes absolute sense. So since you see a lot of you see a lot of women going through this, what do you wish more women knew about asking for mental health support, especially women from communities where seeking help is still stigmatized? I know you mentioned it a bit earlier on. How
Yeah.
would you advise them to go about getting support and still not feel, shamed?
Again, you're never the odd one out if you're struggling mentally, and there is no harm in seeking help that is available. And in fact, with advances in technology, I'm not saying make ChatGPT your doctor or AI your doctor, but there's so many mental health resources. Like I work with Alberta Health Services. If you go on the website, there's the questionnaires are there. We have Mind, which is an app. There's several good quality and evidence-based online resources that you can even just use as a screen in the comfort of your own home. And if you do that quick screen and you're being advised to talk to your doctor, that should push you to do just that. Because if we don't take care of our mental health, it spirals. And when it spirals, it just doesn't affect us as the index patient. It affects our relationships, our children, our community, our work. So if you look at it, taking care of my mental health is taking care not just of myself, but everybody else that's linked to me, either directly or indirectly. So we need to destigmatize it. We need to know that help is available and we need to freely access that help. And while I'm on that, it's not everybody with a mental health problem that needs medication, because that's another thing. Because people may think, oh, they're going to put me on a drug and I'm going to become a zombie and I'm going to be sleeping and I'm going to not be able to function and everybody will know I'm on something because it's going to slow me down. Of course not. So sometimes just getting the right kind of therapy, getting support, psychology, seeing a psychologist, sometimes that is enough to help you through or to help you deal with your mental health problems. And again, you'd agree with me, Dr. Lukoya, there are myriads of medications that we can try for you. So if we try a group and it's not working well for you, there are other groups that we can try, and there are others and others. In fact, I left school 32 years ago this fall, and since I've been practicing, there's so many drugs that are now available for mental health that I never read about in medical school. So the research is ongoing. People worry about their weight. We have medications that are weight neutral. People worry about libido, loss of libido with SSRIs. We have so many other options like Wellbutrin, which is neutral. And there's so many other newer medications that are weight neutral. So you're not going to gain weight on it. It's not going to affect your libido and you'll still live your normal life. So please talk to the experts that can help you so you can start to feel better.
And I do want to bring a few things that the medication picture into focus. About new medications, like you said, there's much more improvement in a lot of medications. And I know sometimes people fear that, oh, the old ones seem to work better than the new ones, or they're the fear of new medications. But this is what I tell my patients. Your phones from 10 years ago, 2 years ago, and your phones now, there's so much advancement. So if your phone or your TV is advanced as of now, why should your medication not not be? So because it is important that some women are genuinely surprised when you talk about advancement in medication. This is something I do want to underline, because most women are not told that their medication doses may need to be adjusted as their hormone changes. A blood pressure medication that was perfectly calibrated at 45 may be too much. Exactly.
Okay, yeah.
When you're 45.
Okay. If we're looking at it that way, definitely.
Yeah, and the hormonal shift changes. It changes the pharmacokinetics of your body. So that is a conversation I think is worth having with your pharmacist and your doctor. proactively. And that's not just
Understand.
when something goes wrong. Don't wait for, things to go wrong before you have those conversations. So, Dr. Roberts, I want to talk about bone health after menopause. What do you tell your patient? I know we mentioned calcium and vitamin D and bone medications. Are there
Okay.
foods that
Of
actually get in
course.
the way of these medications working?
Foods that interact with
Like calcium and
calcium and vitamin.
vitamin
I know
D,
for
or
calcium,
even the timing.
yes, the timing is very, very important. Definitely. And again, that's something we defer to the pharmacist.
Yes,
Seriously.
yes.
Timing of medication for patients on things like Fosamax, bisphosphonates. They need to take that on an empty stomach. They need to drink a lot of water. They need to sit upright for 30 minutes. And that may work for you and it may not. And if it doesn't, it's not the end of the world because there are alternatives. There is Prolia, denosumab, something like that. And then there is the IV medications that you can take once a year for osteoporosis. So
Yeah.
don't feel that if a medication is not really suiting your lifestyle, that you need to stay on it or you need to just manage it or not take it, because not taking it puts you at risk of having an
Correct.
osteoporotic fracture or fragility
Yeah.
fracture, and
Yeah.
that can land you in hospital for years or not years, for months on end. Now, still on bone health, another very important thing that I always like to talk about is the role of exercise and
Mm.
strengthening exercises as well. So it
Yeah.
is more than just moving. We recommend 30 minutes a day, 5 days a week at a minimum. And you got to break a sweat. So whether that's cycling on your, it's not, what do women do? And they say they've exercised. Maybe they cook, they, they, they make an omelette and they think they've exercised. No, you've got to really push and you've got to break a sweat. And then weights. Weights, we recommend at least 2 to 3 days a week. You need to lift some weights for your bone health. And you also need to walk, you need to move, cycle, whatever it is like for you. But I always say break a sweat. Once you've broken a sweat, you know. Of course, check with your doctor if you're a patient with heart failure and you cannot. It doesn't even mean you should not exercise, but you probably need an exercise that is tailored to suit your current medical conditions and situation.
You're quite correct. Because I want to confirm some of the things we said earlier from the pharmacy side. The
Mm-hmm.
calcium supplements taking too close to thyroid medication can significantly reduce the absorption of your medication. So you don't want to put it at the same time.
Mm-hmm.
Timing does matter. And like Dr. Roberts says, there's some of this medication, like alendronate, which is Fosamax, that you take first thing in the morning. You don't lie down because it can affect your stomach and could perforate it. So that's why you're told not to lie down. But there are alternatives. There's certain things you can take instead of that. You can
Mm-hmm.
separate by an hour because with thyroid, you have to take it with water too. You don't take it with coffee or carbonated drinks. So, Dr. Roberts, I'm at this section, which is new. This is new in season 2.
Mm-hmm.
And before we go to rapid fire, it's time for the pharmacy counter. It's a segment where I answer real questions about food, medication, and health
Mm-hmm.
as a pharmacist right here on the show. And Dr. Roberts could chip in if she has one or two things to say. So we
So,
have 2 questions coming this week that are perfect for today's episode. So I'm going
mhm.
to start with the first one. The first pharmacy counter question is I've been having hot flashes and night sweat for about a year. My doctor mentioned HRT but said I should think about it because of my family history of cancer. I'm scared to take it, but I'm also exhausted. What
Yes.
should I be asking my doctor? So I'm going to let you, first of all, go, then I'll go. What should she ask a doctor?
So she needs to ask the doctor why it's contraindicated in her. So when we talk about family history and menopause hormone therapy, we actually look at the index patient. So it's got to be Miss Jane's family history. That's what's most important to
Yeah.
us. So if Miss Jane, as I mentioned earlier, has estrogen receptor positive breast cancer, for example,
Yeah.
menopause hormone therapy with estrogen is an absolute contraindication. If her grandmother had estrogen receptor positive cancer, it is not an absolute contraindication for her to use
Mm.
hormone replacement. More so if she's had her mammograms, breast screening, and everything has been normal so far, one menopause replacement therapy could still be a very safe option and of course with ongoing treatments. Again, if the menopause, for example, if this patient's main symptom was local, and what I mean by that, which is not what we've talked a lot about, is the genitourinary symptoms of menopause, where patients have dryness down in their vagina, where they have painful sex, where they have bleeding and pain when they urinate, frequency urinating, they're not sleeping well because of all the impact of low estrogen in the female reproductive area, more so in the vagina, the vulva, and all whatnot. Local estrogen therapy is safe. So that means we can still give you a pessary that you insert in your vagina that is absolutely safe. And recently I attended a talk, and there the OB-GYN lady was actually saying even with patients with cancer, they have tried it because the amount that is absorbed is so minimal that it's inconsequential. So you need to be talking to your doctor and gathering more information as to why he says there is a family history of cancer. What type of cancer did your grandmother or your mother have that would make menopause hormone therapy contraindicated? So we definitely need more information, but a family history of cancer does not rule out your ability to actually get menopause hormone therapy.
Yeah.
Or
So
HR.
I know that that question is one of the most important questions women in perimenopause ask. And the fact that this lady is asking, it means you're already ahead of most. So here it's what I want you to know. The fear about HRT and breast cancer likely comes from the study we had mentioned in 2002, Women's Health Initiative study. But like Dr. Roberts said earlier on, since that data has been significantly re-examined, the risk picture is much more less than the headline suggested. So it depends on the type of HRT, the dose, the delivery method, where you start, your individual history. A family history of breast cancer does not automatically rule out HRT, but it does mean a conversation with your doctor. You need to be thorough. You need to be specific, not just a quick mention of something you read. You bring it up to your doctor on your next appointment. Ask your doctor specifically, what type of HRT are you recommending? Is it estrogen only or combined? What is the delivery method, which Dr. Roberts just mentioned? What is my individual risk profile giving? My family history, not the average woman's risk, but mine. So you're allowed to ask questions. You're allowed to take the time to decide, and you're allowed to get a second opinion if the first answer does not satisfy you.
And
Your
I'm going to
suffering
chip
is real.
Sure.
Go ahead, please.
I'm going to
Yeah.
just chip this in quickly. Again, we talked about evidence and progress in medical care generally and research and all. Lately, they discovered a part of the brain that's like a thermoregulator. It's like our brain thermostat. And what happens when we hit perimenopause and menopause is that that brain thermostat stops adjusting to the temperature. For example, if it's supposed to be set at 36.6, it's not responding. When it's supposed to stay at 36, it might just go to 38. So with all of this, they've come up with some receptors in that thermoregulatory area of our brains as women that are called the dinky receptors. And now there's a new class of medication that work on this thermoregulatory part of our brain to manage hot flushes. And guess what? It has zero estrogen. It's not hormones. An example is one called Vioza. I don't know what it's called in the US, or Fexolinitant. These are medications that are safe, that can be used, and that are not. So don't feel that even with a personal history of breast cancer, it doesn't rule out the fact that it doesn't mean that you should continue to suffer. Talk to your doctor and look at the options that are available, because menopause therapy is not only always estrogen alone. There's so many other things that can be used, especially this newer drug. And I've heard very, very good
It's about it. Yeah.
feedback and about it.
Yeah. Thank you for chipping that, because it's important to reassure people that there's always help. There's always something else that you can use. So I'm going to go to the second question and the final one before we go to rapid fire. So this question, this lady says, I'm 52 and I've been on a low dose antidepressant for 3 years. Lately, it feels like it's not working as well. I'm more anxious, I'm less stable, not sleeping. My doctor wants to increase my dose. Could this be hormonal rather than the antidepressant not working? Do you want to take that?
It could be either, I would say.
Yeah.
Again, this patient would need to be reevaluated. We will need to really dig deep into the menopause related question, the mental health concerns, and oftentimes both overlap. And if, of course, that was another thing I was going to say, our bodies change as
Yeah.
we hit the perimenopause and the menopause.
Yeah.
First, just digressing to the thyroid, your dose requirement might differ because you gain more weight around menopause. And when
Yeah.
you gain the weight, it's harder to lose. And the most annoying thing is around your midsection where you don't want it because there are more receptors there. Therefore, if you're going to gain weight, that's the first place the fat runs to.
Yeah.
Anyway, so that's one. Again, with mental health, there are a lot of changes. So the dose that might have worked for you in the past may not work for you. One, because you're heavier. Two, because you're experiencing so many other symptoms that also need to be addressed. So there could be an overlap. It could be purely hormonal, but with a patient that has had a mental health history prior to presentation, I will probably focus on mental health while not ignoring the role of hormone replacement.
I think I would also recommend asking your doctor for hormonal panel.
Exactly.
Just to rule out things. You want to see where is the estrogen, is it progesterone, is it my FSH level? Because I know perimenopause could be the driving change and it could be something totally different, but you want to rule out everything possible before your medication doses are changed. This is not a reason to refuse the dose increase. It's just a reason to have a fuller conversation before you decide.
Absolutely.
Please share this, share with your doctor, share with your pharmacist. Both of them need to know
Absolutely.
you're asking this question and you're not being difficult. You're just being your own best advocate, which is
Advocate,
important.
absolutely. And talking about hormone panels, I just need to chip this in.
Go ahead.
I'm going to partially agree and partially disagree with you.
Go
So,
ahead.
the point of agreement with you is for a very young woman. For example, a 38-year-old woman, no medical history, for some reason just becomes amenorrheic and she's not pregnant. Definitely a hormone panel will be indicated. Want to look at her estrogen, her FSH, her thyroid. It could even be stress, but it's always good to check that. But for the woman in her mid 40s without any pre existing
Yeah.
illnesses or to do with the reproductive, cycle, she hasn't had surgery or anything, she's not on chemotherapy for cancer, we actually do not need a reproductive hormone panel. So we may do a thyroid hormone panel, we may do other hormone panels as indicated. But what I'm driving at is that to diagnose perimenopause or menopause, we don't necessarily need blood work, except in a few cases, like a very young patient that we don't expect to be going through that change at the time that they present to us, or if there's an indication otherwise. Because some women would go to some practitioner. I'm an orthodox doctor. So some women will go to naturopaths and will choose to go, and there's absolutely nothing wrong with that. It's their personal choice. And they may want a lot of hormone testing done, and they're well in their rights. But as an orthodox doctor, it's not something I would recommend, except there's a clear indication to do such testing. I just wanted to chip that in.
No, that's okay. And please keep those questions coming because then your question may help somebody else. It may answer somebody else's question or doubts or thoughts. So you can send them to podcast@pharmaplansystems.com. You can drop in the comments, and the best one to go on the show every week. So now, Dr. Roberts, we are at that period where we do something called rapid fire. I ask you questions, you're going to answer real fast.
Okay.
And you ready?
That's right. Let's do it.
Okay. So our first question is one food every woman over 40 should be eating more of.
Grains.
The most underrated supplement for women's health.
Calcium.
Okay, the third question. One thing women should stop feeling guilty about when it comes to their health.
Mental health.
Very correct. Next question. HRT, underused, overused, or misunderstood?
Misunderstood.
Best thing a woman can do for her mental health that does not cost a thing.
Walk.
Okay. Next question. One myth about menopause you wish would disappear forever.
It causes cancer. Treatment causes cancer.
What does a healthy plate look like for a woman in perimenopause?
Half vegetable, quarter healthy protein, and quarter greens.
Good. Because some people will miss it. That's
Of
why I'm
course.
asking it again. So the last question. One thing every woman should ask her doctor at the next visit. If they're listening to this show, what do you ask your doctor next visit?
Be open about your menopause symptoms or perimenopause symptoms. There's nothing to be ashamed of.
Dr. Roberts,
Yep.
thank you so much. It's been a very, very exciting topic. A lot of us were looking forward to this episode.
Thank you.
I know we're going to have more questions because this was before the show questions. So thank you very much. I do want to say 3 things before we end. The 3 things I want people to take, I want listeners to take from today's conversation. First, your symptoms are not stress. They're not aging. They're not you being dramatic. They're data. They're fatigue. They're brain fog, mood changes, weight shifts, sleep disruption. These are your hormones communicating with you. And you deserve a doctor, a clinician who speaks that language. Number 2, HRT is not the enemy. The fear that's kept millions of women suffering unnecessarily is based on science that has been significantly reinterpreted since 2002. So if you've been told HRT is not for you, ask why. Ask specifically. Ask for the evidence. You're allowed to ask those questions. And the third and final one is your mental health. Your mental health and your hormonal health are not separate conversations. So if your antidepressant feels like it's not working the way it used to, if your anxiety has increased, if your sleep has deteriorated, if your mood feels less stable than it did, let your doctor know. Ask your hormones before anyone reaches for a higher dose. The pharmacology of women's health cannot be separated from the pharmacology of women's hormones. So if you want to understand how your specific medications interact with the foods you eat, including how hormonal changes affect drug metabolism, MediMeal Safe, which Dr. Wood mentioned earlier, checks that for you before every meal. And if you want a meal plan already built around your medication list, MediMeal Plan does that too. And both of them are at pharmaplansystems.com. Dr. Roberts, if people want to reach out to you, where can we reach out to you?
Thank you so much. I'm on most social media platforms, LinkedIn as Dr. Tope Roberts, Instagram as Dr. T. Roberts, same as Facebook. I have a website where you can actually know all about me. It's www.drrobertsaetope.com.
So we're going to have all this information in our show notes. Everything we discussed today, just want to be very specific, is for educational purposes only. It does not replace the advice of your doctor, your pharmacist, or your healthcare team. So please work with your care team for guidance specific to you individually. I'm Dr. Remi Olukoya. So eat smart, your meds matter, and your body will love you for it. See you next episode. And if you have a question for the pharmacy counter, send it to podcast@pharmaplansystems.com. Thank you and have a good day.